Hello, everyone, and welcome back to the World Extreme Medicine podcast. My name's Will Duffin. I'm joined today by Karen O'Neill, who's an advanced clinical practitioner who works in Stockport ED near to Manchester in the UK. How are you, Karen?
I'm not too bad, Will. Thank you for the invite to join you today.
Oh, it's great to have you on the podcast. And unfortunately, Karen, you have succumbed. Tell us what's happened.
So I'm now on day 9 of being COVID positive. Took them well, originally low-grade temperature, and had many of the classic symptoms, but pleased to say that despite a little bit of an ongoing pyrexia at the moment, feeling tons better. So bear with me if the voice goes slightly.
You're an absolute trooper. It's great that you're still able to even speak to us, and it sounds like you're on the road to recovery. So I'm really pleased to hear that. But so Karen is an advanced clinical practitioner. So she's a nurse in the emergency department, but she also has a keen interest in global health. She's a regular member of our faculty and was teaching on our Keswick course only recently when this all started to, the pandemic started to kick off. She's got an interest in humanitarian aid, disaster response, outbreak surveillance and control, and has worked for a number of different organisations. And she's worked as the medical advisor to the UK National Ebola Response Programme out in Sierra Leone. And you've done a number of other deployments and other disasters that you've been involved with. Which are those, Karen?
Thank you. Yeah, so I've had the privilege really of working in quite a few different environments. Started originally back in Uganda, living and working there on a development project, and it's a country I'm still involved with in a couple of different projects. I've also had the opportunity to work in India in the slums in Mumbai, and do some paediatric work out in Malawi as well, and was involved in disaster response during the Typhoon Haiyan that struck the Philippines back in 2013. So I was on the UK medical team for that. Yeah. More recently, I've been working with Save the Children on the migrant response. Mm-hmm. And like you say, Ebola was a huge role for me, working as a medical advisor with an organisation called UK Med. And that was the UK's response to the Ebola outbreak in Sierra Leone.
Yeah, so you've had a really interesting and varied career. That's great. So let's talk first of all about Ebola, and it'd be nice to draw out some of the lessons that we can learn from that response that we can take into the COVID-19 pandemic. So can you set the scene for me? We're going back now to 2014 in Sierra Leone. Yeah, tell me how it all kicked off.
Yeah, so that one of the key striking differences immediately is that it was about 8 months for Ebola to be declared a public health emergency. So that was a slower response to the outset. And I think that's one huge key response that we've taken forward, because I think we've all acted during this global pandemic at this time. We've acted very fast. And we saw what was going on in China. We've learned lessons from Italy. We're all learning lessons from each other globally. Ebola, we always, if you can ever be grateful, we were always grateful that Ebola was not a respiratory disease. It was transmitted through bodily fluids and contact. So if you think about Ebola, we had just under 30,000 cases, with about 11,000 deaths, and with a death rate of about 40%. So hugely contagious. Compare that to COVID-19, where, as it stands from the figures today, I think we've got almost 1.5 million cases, 83,000 deaths globally, with a death rate of roughly about 6%, although I appreciate that varies hugely between countries. Yeah. So, albeit Ebola was on a lesser scale, it had a much higher death rate than COVID.
Yeah, that death rate of 40% is quite terrifying, isn't it?
Yeah, absolutely.
But as you say, fortunately, the R naught, the transmissibility of that virus was a lot lower. So I understand it was only slightly above 1.
Absolutely.
Whereas COVID-19 is thought to be somewhere in the between 2 and 3. It varies, but that seems to be the difference between that remaining as an epidemic. So it was localized in West Africa with a few sporadic cases in the US and the UK and also Italy, I think, back then. But whereas COVID-19 has reached true epic pandemic proportions.
Absolutely, and
Yeah.
sort of very similar to Ebola. Back at the
Yeah.
start of COVID, when we started to hear of this disease that was coming out of China, and it wasn't too dissimilar to that back at the beginning of Ebola, when we were sort of starting to hear about these cases. And I was quite familiar with Ebola myself, because the previous current outbreak, the largest global outbreak, had actually been in the community where I'd been working in North Uganda in Gulu. Albeit that wasn't the time that I was working there, but it was still, the memory was still very, very prevalent in Northern Uganda when I was working there. And, the healthcare workers there would be able to tell you about people they'd lost, people that had been infected, and people that were still part of studies looking at the effect of that. So, back at the beginning of Ebola, we would talk about, could this become an epidemic? And it was considered that it was unlikely that it would become an epidemic. And nobody ever imagined it would spread on the scale that it spread, because it'd never been seen before in Ebola.
So what was different then about the 2014 epidemic of Ebola? Because this wasn't the first outbreak. There'd been multiple previous outbreaks in West Africa with localized, more rural locations. But why was it that it spread to all the neighboring countries and ended up affecting a kind of global or international response for fear that it would continue to spread outwards?
I think largely due to the slow response to it, very porous borders as well. The borders in West Africa, this free flow between all the countries in the area, and the nature of how people live. I don't have all the answers to that, if I'm honest, but this was certainly something that was almost even considered, could it be Ebola at first, because of the scale that it was spreading on, and in West Africa.
I see.
And very, very similar. I recall sitting in a meeting probably 10 to 12 weeks back here in the UK about planning ahead of coronavirus or COVID-19, and sort of saying, well, I think we very much need to change the language from not if this happens, but when it happens. And I explained about Ebola and my role in Ebola, and how initially we sat around a table thinking, could Ebola spread on a vast scale? And it was considered that, it probably wouldn't. And then 30,000 cases later, we soon learned our lessons from a slow start.
Wow. So with your experience of Ebola and how quickly that took hold, do you feel like you were slightly ahead of most other people in anticipating this pandemic, that you kind of knew how these viruses can behave and how they can spread through a population?
I think it's impossible to anticipate a pandemic, and it's something that we've always dread. But the respiratory nature of this disease certainly puts it at higher risk of transmission. But I think, having been through something like this before, you could heed the warning signs, particularly when we started seeing spread beyond China. Particularly when we started to see the situation that was unfolding in Italy, then Spain, then France. And we started to see cases in the UK. And, for me, I suddenly had this feeling of familiarity. And I remember one evening sitting at home in my lounge and crying. And I couldn't explain what the feeling was. And I realised actually the feeling was exactly the same feeling I had in Ebola. When we were, everybody that was involved in that response was working absolutely flat out, getting very little rest, concerned about their loved ones, concerned about work colleagues, concerned about healthcare workers on the front line. And, there was barely a day off during the Ebola response in about 8 months. And I remember getting to my first day off and feeling utterly, utterly broken. And I think this is where it's really important at the moment during this COVID-19 outbreak. And I think it's very important that we're talking about well-being, we're talking about rest, we're looking out for each other, because that is so fundamentally important, because we know this isn't going to be here just for a month or 2 months. You know, this could go on for many months to come.
Yeah,
absolutely. And so you were flat out working on the Ebola response for eight solid months. That must have been quite an intense time in your life.
Yeah, indeed, it was. It was a very, very difficult time. But actually, when you're working towards something like that, you're so focused and so driven to do it. And I was working with such an amazing team, and, you know, healthcare workers from the UK putting themselves forward to go and support their international colleagues who were, you know, the healthcare workers out in Sierra Leone were doing a phenomenal job. People that were stepping up to put themselves right on the front line, despite all the stigma within their communities. And, you know, thinking about it now, you know, that's a real difference with Ebola and with COVID-19. As somebody that's just had COVID-19, I've had nothing but an outpouring of love and support from people all over the place, whereas people that contracted Ebola were stigmatized, and people didn't want to go near them. And, you know, many years later, people are still feeling that stigma within these communities.
Wow.
And I think that's something that we're very fortunate not to be experiencing with COVID-19.
Yeah, wow, that must have been really, really difficult for people that contracted the disease in Ebola, for the survivors and their families to be ostracized by their community for having had the disease. And wow, I can't imagine what that must be like.
Yeah, when I worked on the migrant response with Save the Children, and you'd speak to people that were trying to enter Europe, and some people, you know, I'd speak to them, they'd say they were from Sierra Leone and ask why they were leaving. And, you know, they'd be saying, well, we're still completely ostracized from my community, unable to get employment, living in more extreme poverty than they were living in before. And it was hard at the time to hear that, because you thought, we've worked so hard in Sierra Leone to try and eliminate Ebola, yet it's awful to hear that people are still having difficult living circumstances because of stigma.
Yeah, and there's some other kind of nuances to Ebola with regards to cultural practices around how in West Africa the bodies of the dead are dealt with. Can you tell us a little bit about what happened with that, and how that increased the transmission in West Africa?
Yeah, so culturally within the communities, particularly the communities we were working with in Sierra Leone, and it's common in other countries across Africa, West Africa, is that the families deal with the bodies after death. It's cultural, it's respectful. They wash the bodies down, and the bodies are buried very, very quickly. Ceremonies involve touching the dead body, which obviously in Ebola was a huge source of transmission. So burial teams were established that would go in and take bodies away from the community of people that had died from Ebola. And obviously it's very, very distressing then for the families who couldn't hold their traditional funerals. And this caused quite a lot of hostility in affected communities, because they didn't want their loved ones being taken away. And there was a lot of work done at a local level to try and get the burial teams accepted by the families to lessen the grief for them. And it was simple things like the colour of the body bags. So the body bag colour had to be culturally acceptable. Things like establishing female burial teams, not just male or combined burial teams.
Yeah.
And, you know, it is sometimes where I do see some parallels with COVID, in terms of loved ones can't be with their relatives if they're dying of COVID or suffering with COVID. And, you know, I think the UK health workers, and I'm sure it's the same across the globe, are doing an absolute phenomenal job to be with those people, to try and avoid a gap where families would ordinarily be at their side, to use technology to interact with families that can't be with their loved ones and be at their loved one's side. And also there's the cautions after the person has died of COVID-19 that the mortuary have to take. So at every level, we've got people doing phenomenal work. The mortuary teams have really stepped up, and they're doing a fantastic job to try and ease the pain for families as well.
Yeah. It just seems unbearably cruel that COVID positive patients who are hospitalised, who are severely unwell, that to reduce transmission, infecting their loved ones, that their loved ones aren't able to be by the bedside with them as they would be in any other circumstance. I just think that's it's awful for the patients and families and the staff having to kind of work through that.
Yeah, absolutely. And I think it's where we've got, extraordinary healthcare workers that are doing their absolute best. I've always had a motto that you treat every patient as if they're your own relative. And if that involves giving that person a little longer than you ordinarily could give them at this time, that's more important than ever before.
Yeah, absolutely. And so going back to Ebola, what was there a particular turning point in that epidemic where you started to see the mortality falling, or think the situation improving? And can you remember that happening? And
yeah, I think it was always very reassuring. I think very similar to now in this current pandemic, we were watching those numbers that were produced every day, and when you started to see them going down, and particularly when you started to see survival rates improving as the communities had more trust in you, and they could see that people were surviving and going to Ebola treatment centres earlier, which was giving them a better chance of survival. That became very, very heartening. But at the same time, what you got with that is you got people being more lax maybe in their precautions. So, very similarly, in Sierra Leone, they had isolation measures, like we do. Yeah. And public gatherings are a huge thing in Sierra Leone. Parties on the beach on Sundays and family gatherings, and dancing's a phenomenal part of their culture. And I'd previously been to Sierra Leone before the Ebola epidemic, and seen how busy the beaches could be at the weekend, and people weren't allowed to go for a walk on the beach anymore, and the police were very, very stringent about these measures, and that did help gain some control. But as the numbers went down, people started to get a little bit more lax. You could pass through some border controls and they wouldn't be checking your temperatures anymore. Or in my experience of being there myself, the buckets of chlorine that were normally outside shops or at different social points weren't there anymore. And then suddenly we did see another spike in cases, and we did see another outbreak. And we, I remember liaising with a team that were out in Sierra Leone at the time, and they had this huge outbreak, and we'd started to send less people to help. So suddenly, the international and the national workers in Sierra Leone had this new spike in cases and were absolutely overwhelmed. So I think it's where we have to heed the caution that if our social isolation measures do start to get reduced, we do have to still be careful. We still need to be washing our hands. We still need to be very careful, in how much we do have contact with people.
Yeah, absolutely. And it's interesting how the government in their strategy has anticipated a degree of non-compliance within the population. I think their modelling will be based on a roughly 70% compliance to social distancing, lockdown measures. Just recognising that within a population, I think there's always going to be a cadre of society who just won't play by the rules. I think, like you say, if the lockdown is relaxed, how can we be sure that people will not will take those new freedoms and take them to the extreme, and we suddenly get a second spike in the UK? I mean, that's it's a very real problem, isn't it?
Absolutely. And I think the majority are heeding the advice of social isolation, but equally we don't need the majority, we need everybody. Nobody's immune. This doesn't discriminate. And people really need to consider not just the impact on themselves, but on their loved ones, and also on healthcare workers. Because, for example, now I've been out of action now for 8 days. I'm going to be out of action longer because I still have a temperature. And if I'm at home and well, I can't do my job and look after them or their loved ones. So it's a very frustrating situation when people don't think that the rules apply to them.
Yeah, absolutely. And it's a little bit alike voting in an election, isn't it? It's something, I think, from an individual basis, it might feel like meeting up with a friend or going to visit your second home if you're a Scottish politician, a Scottish health minister, for example, or these kind of small freedoms that you might allow yourself, these exceptions that you make on an individual level may not seem to make a big difference, but actually, if everybody in the population did that, we'd be in a real predicament. It's that kind of collective sense of social responsibility that we need to engender in everyone. And anyone listening to this who's medical or non-medical, I completely agree, Karen. We really need to, everyone does need to just stay at home, don't they?
Yeah, and it's the same for the health of all our key workers, because if we don't have our key workers, we don't have that network of support that we're all currently relying on.
Yeah, absolutely. Yeah. I mean, for you as frontline nurse in the emergency department, that must feel very disempowering and frustrating that you can't be there to help your colleagues.
Yeah, absolutely. And it was actually on a night shift that I took unwell. I just felt really unwell, checked my temperature and realised it was high, and I actually left shift in tears because I felt so strongly that's where I should have been, and I felt like I was letting my team down. And my team was sort of frustrated because they couldn't hug me because they obviously couldn't touch me. Yeah. But I work with a phenomenal team, and they are all trying their absolute best. And I think it's really where we had some time to prepare. My trust have been doing fantastic work in their preparations, and I hear the same up and down the country. I know areas, there's parts of London that are having huge numbers of cases. We're seeing a substantial number of cases, and up to the point that I went off, we were seeing more and more. And pretty much every patient that came into the emergency department was queried COVID-19.
Wow.
So at the point you left, were you still having hot and cold zones, or had that gone by then?
No, so we've still got running a hot and cold COVID hot area of the emergency department, and then the cold for everybody that's non-COVID, because I think that's the key here to remember, is that other illnesses and injuries, they don't stop because of COVID-19. And what we were seeing, and I believe this is the trend across the UK, is that the non-COVID-19 presentations, so that chest pain and people abdominal pain, all the conditions that we normally see an abundance of in the emergency department, we're just not seeing. And that's a huge worry, that people are staying away because of the fear of coming to a hospital, or the worry of burdening us. It's not a burden if you've got chest pain. We want to see you in the emergency department. If your child's unwell, we still want to see you in the emergency department and not feel that there's nobody there for you. And I think that's a really important message to put out to people, that you still get ill and it still might not be COVID, and you still might need health services, be it your GP or 111, who are, again, another group of people doing phenomenal work and absolutely overloaded right now. But there are other things going wrong for people, and I think as a healthcare profession, we are worried about where those people are right now.
Absolutely. And in terms of staff sickness, so you're off work at the moment within your department as a whole, has that been a big issue?
Yeah, indeed. We have got a fair number of people off sick at the moment, which again, is another worry. But the trust trying, people from all across the trust are being redeployed. There's lots of contingency planning for staff going off sick. Everybody's doing increased numbers of hours. We've got consultants working 24 hours a day. So despite the fact that it's a really difficult and a very, very challenging time, I think the sense of community right now is fantastic, and people are really, really pulling together.
So there's a real camaraderie in your department.
Yeah, absolutely. I mean, I think I described it to somebody yesterday as like a protracted major incident, you know, and people are finding it hard. People are really finding it hard. You know, people that you wouldn't have expected have said, you know, I'm crying every day. And I think that's a completely normal response in a very abnormal situation. And I think, you know, it's important to all be really looking out for each other, because when you're on, you know, when we're all talking about how we're feeling and our emotional well-being right now, I think a lot of people are struggling.
Yeah, absolutely. And when you're on shift, Karen, what kind of things are you doing to safeguard your well-being to help you get through that shift?
I think a lot of it's talking to each other. Our trust have opened up what we call a sanctuary, so a room that staff can go to if they need it. We've had no end of thoughtful and kind donations from across our community, be it local restaurants sending us food in, people sending, you know, thoughtful things like shampoo and toiletries so we can shower at work, people making headbands for us and bags to take things home in for us. You know, and small gestures like that make a huge difference. They really, really do.
Yeah, I think the outpouring of support for health workers and key workers on the whole has been just phenomenal from the general public. And the Thursday applause, I just find that really emotional. It's just so powerful, isn't it? When you go out on your street and then everyone's kind of clapping and cheering. I just think it really motivates me. It makes me think, hey, look, I need to really get out there and deserve these applause. I need to do something to really make this, you know, to honour that.
Yeah, it's so true. I mean, last Thursday I was really unwell last Thursday, so my husband opened the window and I could hear all my neighbours shouting, you know, Karen, this is for you, and clapping, and you know, it reduces you to tears because you know you can't believe that people are clapping for you. And you think, oh, that's for me.
Yeah, that's quite amazing, isn't it? It really is. And so in your department, how are patients managing this? Are you seeing a lot of patients who are very fearful, just kind of petrified? Is it how are they coping with the kind of COVID era healthcare?
I think patients, understandably, are very frightened, and I personally found it very, very difficult as an ACP when I've had to, you know, it's a patient I'm treating, and I've had to say to them, look, I think, you know, you're showing all signs of COVID-19, and they look petrified, and then, you know, having to then relay that to families as well, and having more end of life conversations and conversations about ceiling of care. And I don't think I appreciated until I've had a little bit of time to reflect with being off how much that was getting to me, that how many do not attempt cardiopulmonary resuscitation forms that we've been filling out, you know, more so than ever before. And I think that's really, really difficult. And I think in yourself, that's a huge part of the learning and growing in this response, is how you approach those conversations with the utmost dignity, and how to handle that.
Yeah, and I think certainly for us in primary care, we're preparing ourselves for a huge demand in palliation, in cases that will be discharged from hospital that will need care in the community, optimise their comfort and dignity in the last days of life. And I think we're going to be spending a lot of time doing home visits and having some very difficult conversations. There's likely to be a shortage of syringe drivers. We're looking at alternative palliative care, drugs and modes of delivery that will meet the demand, that the kind of sheer numbers that we'll be seeing. And I think that is the next big thing certainly for my end. But I think you're ahead of, in the emergency department, you're ahead of the curve. You're seeing you're seeing that right now. That must be really, really tough having those conversations with people.
Yeah, very, very difficult. But ultimately, you want to give everybody the dignity and the respect that they deserve, and that's absolutely paramount right now. And it's new learning for all of us in terms of, it's been a long time. It was a junior nurse when I was last involved in palliative care, and we do very small amounts of it on occasion in the emergency department, but it's learning about palliative care all over again. And for me as well, I qualified as an advanced clinical practitioner last November, so it's the learning curve during this response again has been phenomenal.
I feel like every shift I go into, I'm having to read a whole new, there's so much has changed in the last 24 hours. I'm having to just read up on so much more stuff, and I always feel behind. It's so difficult to keep up to date with what's going on, isn't it?
Absolutely, Will. And I think we hear that from all healthcare professionals. It's like you're having the update of the update of the update guideline, and I think a lot of people, we go into work, we're doing extra hours at the moment, which none of us mind. This is our call, but also what we are doing in our own time is spending hours trying to read the most updated evidence, read the most updated guidelines, share best practice amongst each other. I've been blown away by the number of webinars that have been put out there. The grand round for my hospital today was done via Zoom, and updating us on the latest figures, the number of COVID positive patients in the hospital, updates going on in the hospital, daily briefings, and
it's great to see that information flowing freely around the medical community, and actually the wider community as a whole. For example, the pattern for making face masks with a 3D printer, that has been shared patent free, so that anyone can produce these masks, and we're seeing this kind of level of information sharing on a scale I don't think we've ever seen before, which is all in the spirit of community and the fact that we're all in this together and that we're here to help one another. I think that's been really, really amazing.
Yeah, I think you can see that as well in the number of people that have returned to practice, stepped out of retirement, all our expedition colleagues that currently aren't able to go anywhere on expedition. So, they're supporting the NHS during this time. And I just think that is like phenomenal testament to our healthcare colleagues for doing that.
Yeah. Okay. Yeah, it is. That everyone out there who's wherever you're working, whether you're paramedic, nurse, GP, a healthcare assistant, anyone, you're doing a phenomenal job. It's we're all part of a very, very special team.
Absolutely.
In terms of your work, when before you were off sick, when you were working in the emergency department, presumably you were in fairly full-on PPE. You would have had a respirator mask and a visor and gown. Is that right? You were.
Yeah. So, as we all know, PPE, personal protective equipment, has been a very changing situation.
Yeah.
Is probably a fair statement. And I think it's an area that's caused everybody a lot of concern, because right back at the beginning, when we were getting, the occasional person into what's called the pod for assessment, maybe they'd travel to some of the Category 1 countries like China or Iran. And, back in those days, we were putting full PPE on, including the fit-tested masks. And that was just to take a swab. And now, that for that process now, you're wearing a standard apron, gloves, and a surgical mask, and eye protection to take a swab. So there's been huge changes in the last 2 to 3 months in the PPE, and I wouldn't be surprised if we see big changes in that again going forward. So that in itself is quite confusing, and in trying to keep up with those changes as well.
So even for suspected COVID positive patients, you were just wearing a surgical mask?
Absolutely, yeah, absolutely.
Did you feel very exposed? Did you feel quite vulnerable with that?
I think because I'd been quite involved in the training for the donning and doffing the PPE, so taking it on and off. I personally felt quite secure, and I felt quite reassured that it felt like the hospital had a good supply of PPE. How that might have changed now, I'm not 100% sure, because I know there's been new guidelines since I've been off.
I think there's probably been like 6 or 7 different guidelines since you've been off, Karen. It's constantly evolving. And one thing we do know is that whilst there are allegedly huge stockpiles of PPE, the amount of product that's reaching the front lines is hugely variable. And what's been amazing, certainly in Bristol, there's been a huge community response to that, and lots of kind of local industry around here is in the business of manufacturing and sourcing its own PPE, masks and aprons and things are all being produced. Even scrubs. I've got some scrubs made for me by a bridal shop on Christmas steps in Bristol, and they've been amazing. They're making scrubs for health workers for just the cost of materials, and it's just that, that, again, that's all part of that incredible community spirit.
Oh, it's absolutely phenomenal. One of the really kind donations we had was a local school that had donated all their chemistry goggles. It just blows you away that people are thinking, thinking about our protection from what they hear on the news as well.
Yeah, wow. Yeah, and I understand. So you're at home, your husband. So you've tested positive for COVID. You've still got the symptoms. You've still got the fever. How is that at home with your husband, who at the moment doesn't have any symptoms? That must be really, really difficult trying to live together and to protect him. How is that working?
So maybe living rather separately. Thankfully, he's not shown any symptoms himself. He was swabbed, but had an insufficient swab, unfortunately, being a key worker himself. But it's difficult, particularly when it's a distressing time, and you very much underestimate the power of the hug when you really want that hug and you can't have that hug. And it's the simple things that you realise that you go to do. You both go to touch the same thing, and then you're wiping things down avidly, and even just go to make a glass of water for I go to give him a glass of water, and we're trying not to touch the same thing. So it's all the things that you actually take for granted in terms of sort of human contact.
It must be very difficult. I mean, the advice is to try and have separate bathrooms and live in different areas of the house. But unless, for those of us that don't live in mansions, it must be really difficult to do that, to not have both go into shared spaces.
Yeah, absolutely. And I don't think everybody's that fortunate, are they?
Absolutely. Well, Karen, it's been a real pleasure talking to you. I'm sending you a huge virtual hug right now. You've been amazing on the front line. I know you'll definitely be back in action very soon, and it's been incredibly frustrating being stuck at home. But on behalf of everyone at World Extreme Medicine, we really hope that it's a quick road to recovery for you.
Oh, thank you so much, Will. Appreciate it, and you stay safe too.
Thank you. Before we close, was there anything else you wanted to add?
I just want to say a huge thank you to all key workers out there, because you're doing a phenomenal job, and we appreciate it so much. Thank you.
That's great. Okay, well, thanks so much for your time, Karen. If people wanted to ask you any questions or reach out to you, what's the best way for them to do that?
Via Twitter, via any kind of social media, or via WEM.
Yeah, it was so great to chat to you, Karen, and get well soon. We wish you all the best.
Thanks ever so much.